Very good day to you, ladies and gentlemen. My name is Kamran Salim, and I am a diabetic foot orthotist by profession. I have had a lot of experience working abroad for about 20 years outside Pakistan, and the highlight of my career was working with um, a German professor, Professor Weber, at the University of Aachen in Germany. So I've got extensive experience as far as the diabetic foot is concerned, and especially the prevention and the treatment like debridement and stuff like that for the ulcers. Um, Today we are going to discuss module number 8, which is toe and flow peripheral arterial disease in diabetes. And the objective of any program, diabetic foot program in any country of the world right now, is to save the patient and to save the limb, because it has been seen that a lot of um, expenses can be saved if we will work on the prevention of ulcer rather than the treatment of ulcer. So a lot of health systems in the world are now concentrating on the prevention of ulcer. So this program is also to save the limbs, because limbs are life. So diabetic complications, basically they start from diabetes. And diabetes um, causes neuropathy, which results in ulceration and vascular impairment, and then leads to infection. And when the infection deteriorates, then it can also lead to amputation. So it's basically a cascade of different problems, which results in amputation of the foot in case of diabetic patients. Peripheral arterial disease happens when buildup on the walls of the blood vessels causes them to narrow. So the lumen of the vessels decreases due to the accumulation and plaques. It commonly affects people with type 2 diabetes who are also prone to high cholesterol and heart disease. According to the American Diabetes Association, about 1 in 3 people with diabetes over the age of 50 have peripheral artery disease, and doctors most often diagnose PAD when it's causing leg or foot problems. And the possible signs of peripheral arterial disease include pain in your calves when you're walking or exercising that goes away with the rest, which is called intermittent claudication. Um, the sign of claudication is that when you will ask the patient whether the pain stops when the patient stops the activity, the patient will say, yes, it stops when I stop the activity, and it comes back on when I start walking. So that is the sign of intermittent claudication. The patient will also complain of numbness, tingling, or the feeling of pins and needles in the lower legs or the feet, and cuts or sores on your legs or feet that don't heal, or they are healing slowly, is a sign that the patient might be suffering from peripheral artery disease. So about 50% of patients with critical limb ischemia, the advanced stage of peripheral arterial disease associated with lower extremity amputation and significant mortality, also have diabetes, and they fare worse than non-diabetics. So critical limb ischemia is basically a condition where the limb is not getting any more um, perfusion, and thereby it has hypoxia. Now, prevalence of peripheral arterial disease by age group. So if you see the prevalence is above 80. With if the age increases, then of course the prevalence of peripheral arterial disease also increases, uh, and it has somehow been seen that it's more prevalent in men rather than in women. And people with diabetes are at increased risk of developing PAD, which occurs when the peripheral arteries, those that do not supply blood to the heart and brain, become narrowed by an accumulation of fats, cholesterol, and other substances, a condition known as atherosclerosis. People with diabetes are more likely to develop atherosclerosis, which can progress to PAD. Majority of patients will be asymptomatic, and ischemia will be diagnosed on screening examination. Ischemia should never be taken lightly. All patients with absent foot pulses should have their pressure index measured to confirm ischemia and to provide a baseline so that subsequent deterioration can be detected before the patient presents with irreversible lesions. Furthermore, the detection of peripheral vascular disease provides an extremely important opportunity for management of atherosclerotic risk factors to prevent future vascular events in the coronary and cerebrovascular area. If symptoms do develop in the foot with ischemia, there are three main clinical presentations. The first one is intermittent claudication, which I have already explained. The second one is severe chronic ischemia with or without rest pain. And the third one is acute ischemia. The classical site of claudication is the calf, although it may occur in the thigh, buttocks, in aortoiliac disease. Basically, if it is just restricted to the calf, it is called classical intermittent claudication. And if it is in the buttocks and the thigh region, then we call it non-classical intermittent claudication. It is less common in diabetic patients compared with non-diabetic patients because of peripheral neuropathy and very distal site of atherosclerosis in the tibial vessels of the diabetic leg. Patients with claudication rarely have vascular intervention, and operative intervention is required in only 1% of diabetic patients per year, although it may be indicated when the claudication is severe. That is when pain comes on within a few yards of walking. We have a standard distance of less than 100 meters, and the site of the arterial disease is in the iliac arteries. Patients with claudication should enter an exercise program. With increasing severity of occlusive arterial disease, patients may develop a pink, painful, pulseless foot. The color of the skin is a strikingly bright pink, and the foot is cold. The amount of pain will be related to the severity of the disease and the degree of peripheral neuropathy. When it's mild, patients will have classical rest pain, which is a constant pain, often worse at night and relieved by hanging the leg down outside the bed at night. It is important not to mistake the pink painful ischemic foot with an infected cellulitis foot. The pink painful ischemic foot is usually cool, and the infective cellulitis foot is usually hot. If the leg is elevated, the pinkness of ischemia will fade, while erythema of cellulitis will remain the same. A sudden occlusion of a major artery, usually popliteal or superficial femoral, will result in a pale, painful, cold foot with purplish mottling. Initially, the skin is intact, but if the treatment is delayed, digital necrosis will develop. Acute ischemia is a rare complication of the stage 2 diabetic foot and can present very suddenly in patients with no previous history of vascular problems, patients with a history of steadily deteriorating chronic ischemia, patients who have previously had peripheral arterial disease, which occludes, or angioplasty with recurrence of stenosis or occlusion. A 68 years old man with a type 2 diabetes of 9 years duration complained of pain in both legs for the previous 3 months. This pain was worse at night. He got relief by hanging the legs over the side of the bed. He was a heavy smoker. On examination, he had a stocking distribution symmetrical neuropathy. However, his foot pulses were absent, and his transcutaneous oxygen was 28 on the right and 25 showed bilateral iliac disease. He underwent iliac angioplasty, and his pain was partially resolved but not eradicated. Therefore, he was also treated for painful neuropathy. So the diagnosis of peripheral arterial disease is done by looking at the clinical symptoms, doing the physical examination. Then there are bedside tests, and the best one is ABI, which is the ankle brachial index, CT angiography, and MRI. So the clinical evaluation in peripheral arterial disease, if the patient is complaining of intermittent claudication, nocturnal pain, rest pain, has got cold feet and non-healing wounds, then you will include peripheral arterial disease in your differential diagnosis and will try to ascertain how much of a peripheral arterial disease the patient has. Ischemic foot ulcer, physical examination, peripheral arterial disease can be recognized by simple examination. The color, temperature, shiny skin, hair loss on the feet and leg, and hair loss would signify that there's not enough perfusion in the tissue. Palpation of pedal pulses, non-healing wound which require repeated debridement, painful especially with necrosis or slough with poor granulation. So the palpation of pedal pulses, there are two main pedal pulses in the foot. One is the posterior tibial artery and the other one is dorsalis pedis artery. So the clinicians should know how to palpate these two arteries and should make it mandatory in their clinical examination if the patient is coming with diabetes and even if he has or doesn't have any foot problems, the pedal pulses should be checked. And then the angiogram, this is an x-ray of the arteries and veins to detect blockage or narrowing. This procedure involves inserting a thin flexible tube into an artery in the leg and injecting contrast dye. The contrast dye makes the arteries and veins visible on the x-ray. And then the ankle brachial index, ABI, is a comparison of the systolic blood pressure in the ankle with the systolic blood pressure in the arm using a regular blood pressure cuff and a Doppler ultrasound device. To determine the ABI, the systolic blood pressure, the top number of the blood pressure measurement of the ankle is divided by the systolic blood pressure of the arm. Then we have magnetic resonance imaging, the MRI, or magnetic resonance angiography. This non-invasive test uses a combination of a large magnet, radio frequencies, and a computer to produce detailed images of organs and structures in the body. Your doctor injects a special dye during the procedure so that the blood vessels are more visible. Photoplethysmography. This exam is comparable to ankle brachial index except that it uses a very tiny blood pressure cuff around the toe and a PPG sensor, infrared light, to evaluate blood flow near the surface of the skin, to record waveforms and blood pressure measurements. Now there are different tests with the corresponding methods and also what they assess. If you look at the Doppler ultrasound, the method is through the sound waves and it looks at the blood flow in your vessels. The ankle brachial index test is done through ultrasound and blood pressure cuff around your ankle and arm, measured before and during exercise, and it somehow looks at the comparison of blood pressure readings in your legs and arms, as lower pressure in your leg could indicate a blockage. Angiography, the method is by injecting dye in a catheter that's guided through the artery, and it looks at the flow of dye through the blood vessels to diagnose the clogged artery. The magnetic resonance angiography, the method is magnetic field imaging, and it looks at the image of blood vessels to diagnose blockage. Last but not the least is the computerized tomography angiography, the CTA. The method is through the X-ray imaging and the image of blood vessels to diagnose any blockage. So we have to stratify the patients according to what is the result of the ankle brachial index. If the patient is between 0.9 and 1.3, then you can say that the patient has got normal perfusion in the tissue. And from 0.6 to 0.89, you've got mild PAD. From 0.4 to 0.59, you have a moderate obstruction, and less than 0.4 is denoted as a severe obstruction. On the other hand, if it goes above 1.3, which is serial number 1 in this slide, it means that you've got calcification in the vessels and you've got no compressibility in the vessels anymore. So this is a false good result. You will also take this patient as a patient having peripheral arterial disease. So angiopathy ischemia, it is an additional trauma with extrinsic factor and it causes gangrene. So the most important thing is the lifestyle changes to control risk factors, aggressive treatment of existing conditions, medicines to improve the blood flow, vascular surgery, angioplasty, and in the angioplasty we've got balloon angioplasty, arthrectomy, laser angioplasty, and stents. So here you can see the different procedures, how these procedures are performed. So peripheral vascular disease can affect all types of blood vessels. Blood flow is restricted to the tissue because of spasm or narrowing of the vessel. This disease more often affects the blood vessels in the legs. The most common symptom is pain, which becomes worse as the circulation more limited. Restoring blood flow and preventing disease progression is the goal of the treatment. So we've got a few questions and answers according to the American Diabetic Association about how many people with diabetes over the age of 50 have peripheral arterial disease. So it's 1 in 3 people. And the second question is, in occlusive arterial disease, the color of the skin is strikingly bright. It is bright pink and the foot is cold. Question number 3, non-invasive test uses a combination of a large magnet, radio frequencies, and a computer to produce detailed images. And this procedure is called MRA, the magnetic resonance angiography. Question number 4, procedure in which the blocked area inside the artery is shaved away by a tiny device on the end of the catheter. It is called atherectomy. Question number 5, restoring blood flow and preventing disease progression is the goal of the treatment for peripheral vascular disease. And with that, I thank you very much for taking part in this course.